And hey, everybody, I'm Olive Shaw. I'm here with Dr. Holly Caretta-Weyer, one of our SAEM Keynote speakers this year. And we're going to be discussing her topic, which is competency-based medical education. A little bit about Dr. Caretta-Weyer. So she's currently the Director of Assessment and the Interim Associate Dean for Admissions at Stanford University School of Medicine. She's also the Director of Assessment for the Department of Emergency Medicine and Chair of the Clinical Competency Committee. She went to medical school at University of Wisconsin, where she graduated AOA with honors in research, and she stayed there for her emergency medicine residency as well, where she was chief resident. She also completed a medical education scholarship fellowship at Oregon Health and Science University and completed her master's in health professions education at the University of Illinois, Chicago. She's currently pursuing her PhD with a focus on competency-based education systems with a completion planned for March of 2025. So a very busy past and a very busy future for Dr. Caretta-Weyer, but thank you for making some time to join us today.
Thanks for having me.
Absolutely. Well, I just wanted to kind of give you an opportunity to kind of talk about your area of interest in competency-based medical education. I think we've had a lot of changes with regards to how we do assessment and progression in specifically graduate medical education, but all medical education really, including undergraduate. So what kind of changes do you foresee coming in this kind of world in the next few years? And what kind of should we be prepared for as educators?
Yeah, so competency-based education is really focused on ensuring that our learners are able to meet the needs of the patients they take care of. And really, it's about ensuring that they're prepared, right? So competency-based education is really focused on patients and society, but it's also centered on learners and what they need in order to meet the needs of patients. And the whole premise is that it's going to kind of make education more of kind of this continuous growth and development process, right? So we experienced it very discontinuously. At least I know I did, where you have your medical school training and then there's graduate medical education, and then there's your first year as an attending where it feels completely different. Like everything feels like this very disjointed, disrupted process where you're starting over constantly. And really, our growth and development isn't that, right? Like you continue to grow and develop, you just experienced it in a very discontinuous way. And competency-based education is really trying to turn that on its head to say, it is one continuous growth and development process. You may change settings, you may change contexts, you're changing kind of your focus, but it shouldn't be a disruption and kind of this reset every time of trying to figure out, where are you and how do we continue to help you on that journey to take care of patients.
Makes a ton of sense. I mean, I think it's like from my personal experience, it's been extremely disruptive, right? Every time you finish that like 4-year cycle or whatever it might be, to get put into a new place, and all of a sudden the expectations are very different, right, than what you're used to, and you have to kind of try and meet that demand. And everyone deals with that a little bit differently. I think we kind of can respect that. It's a lot of the challenge that we have when we're assessing our residents. With regards to competency-based medical education, I get lost a little bit in the word salad sometimes, I'm sure I'm not alone, because we've talked about, from my time as being an educator, we've talked about everything from like milestones and incorporating those as part of our assessment. Then now we have like entrustable activities as well. So EPA sometimes they're referred to. Then we have like all our other word salad-y things like OSCEs and, simulation assessments. How do they all kind of go together? And is competency-based education going to kind of replace those things, or is it going to be a way to kind of bring them all together?
So the purpose is it brings it all together, right? So the way I like to reframe this for people is entrustable professional activity is totally, you're right. It sounds like word salad, mouthful. I like to reframe this as everyday physician activities, right? When you think about an EPA, it's like lead the resuscitation of a critically ill or injured patient. We watch our trainees do that every day. We do that every day. We have been doing that since before we coined the term EPA. And really each of these things incorporates a bunch of different domains of competence, right? So if you're going to resuscitate a patient, I would expect that you have some patient care skills. You've probably got some medical knowledge, some knowledge of systems-based practice, communication, and each of those different domains of competence has milestones. So we're not throwing any of these frameworks away, because I think that's what people worry about. They're like, I got used to this thing. Now you're telling me I have to get used to something else. We're trying to simplify this for frontline assessors, right? Like frontline faculty are like, yeah, I watched you do that thing. Great. And really trying to say just how much supervision did they need for that given patient on that given day in that given context. and what kind of feedback can you provide to them to help them get better for their next shift? Really, it's for the competency committee to take that step back and synthesize all of that information and say, okay, if they're having trouble with leading a resuscitation, which of these things is causing the trouble? Is it the communication? Is it the patient care? Is it a specific subcompetency that ties to a specific milestone? Like that's where the milestones help, right? When you're seeing these kind of bigger issues, how do you take the big step back and say, root cause analysis, like what's causing the problem? Where do we need to intervene? So we're not throwing any of this stuff away. It all integrates, but frontline faculty just need the ease of like, here's what I'm seeing. Help me help you, right? Like give the feedback and get you the information. Like I don't need to sit here and try and deal with like the which milestone is it, right? That's for us on the back end to say, I'm seeing all of this data. Like that's the premise of competency-based education. It's the promise. But I'm seeing all of this information. How do I take all of these dots, like pointillism, like Georges Seurat, the painting of the picnic? How do I take all of these dots and figure out what picture I'm seeing? Is it the dog? Is it the umbrella? Is it the picnic basket? Like what's happening here? And then what do I need to do, we as educators with the big picture to help this trainee grow and develop? Like, what is the exact thing that I need to help? That's, competency-based education uses the organizing framework, all of this assessment data, really to drive coaching and individualized learning, right? I am here to help coach you to focus on the things that actually will help you grow and develop, to meet the needs of patients, to help you be a confident, competent clinician, and also to meet your professional development goals and all of that stuff, right? Like it's a very holistic approach, but it also is designed to kind of simplify things to what am I exactly seeing? Because a lot of faculty, really struggle with the why am I in the weeds, right? I'm just here to do my clinical job and provide the good feedback.
Yeah, I think that's huge actually, because one of the things that, I've seen too with the milestones is it gets very granular, right? And maybe on a particular shift, especially for EM in particular, like particular shift, all those things might not apply. It's
Right.
difficult to figure out what category it's in, or where the resident should be based on their progression as like a PGY, whatever they might be, right? Like the
Exactly.
milestones don't necessarily line up, which is always a big point of confusion, I think, for the assessor. So I really like the idea of like being able to go to like, can they do this task, right? And like, how do they perform at this specific task that's relevant to our shift today? I think one of the things that I've seen is like, there's always like this inconsistency, right? Especially in EM specifically, like depending on what patients you had that day, the level of chaos of the shift, or, level of critical care that the person provided, what other support staff you might have had on a particular shift. Like the assessment is going to be hugely different. So how do you incorporate that into like a competency-based system? Is there a method on the back end to kind of synthesize that information, come up with the most reasonable explanation for how the resident's doing or a trainee's
Yeah,
doing?
absolutely. I mean, I think this is both kind of the dots that we're talking about, right? Like each shift, each assessment, maybe you do multiple on a given shift, like you did differential diagnosis and resuscitation, and maybe you were running the department. I gave you a bunch of different dots that day, and all of these dots over the course of 3 months, say, will provide kind of this trajectory in each of these different domains, and you'll be able to see like, okay, some of these shifts are total outliers, and we would expect that, right? And again, based on what you're saying, right? Like maybe the complexity that day was super high. Maybe half the nurses you work with were travelers, and you didn't know, like you as the attending didn't necessarily know how much to trust the resident in this new setting with all these people and this team that they'd never worked with before. Or maybe you as the attending were just hangry that day. I don't know. And just less trusting. And, you gave a little bit of a lower rating. And maybe there's other days where this resident comes in, absolutely knocks it out of the park, and doesn't really need your help at all. There is going to be kind of this clear developmental line, that kind of your curve that goes through all of this data, where you're going to be able to say, okay, this makes sense. There's outlier data, there's non-outlier data. I think there's also so much merit in looking at the supervision rating and the narrative, right? Because you're going to have some attendings who are always like, I had to do it for them, or like I had to help a ton. And then the narrative is like, practice ready, greatest resident ever.
Yeah.
You focus on what you can do when you're out in practice, and you're like, there's a disconnect here. And maybe you look at that attending and you're like, oh, they're always saying this, but the narrative is where like the truth is. And I think that kind of correlation of what we're seeing in the ratings and what you're seeing in the narrative is really helpful for context, both for the competency committee to be like, here are the trends I'm seeing, but also for the resident to be like, okay, this rating is whatever. Like the narrative is the important part. The feedback that I'm getting that kind of gives me the here's what I should work on for my next shift is the part that like I can take and use for myself. It's like every piece of feedback, right? Like you take the negative truth and you're like, I'm going to use this. And maybe this part doesn't necessarily apply to the next shift. I think people are so caught up in that it has to be perfect when it comes to feedback. They don't kind of think to themselves like, it's a conversation. Like I'm here to help coach you to be better. And not everything I say to you is going to be the perfect thing that helps you grow for your next shift. You may try that and it may not work. And maybe you come back to me and say it didn't work. Like, what else can I try? Or maybe you'd ask your next attending or your next senior resident, like, what is it that you do that, helps you in this domain? And I think just that continued conversation over and over and over again, every shift is really important. And again, looking at that learning curve, like eventually you have multiple learning curves for your program for residents. You're going to get an expected curve. And that learning analytics piece is going to say, okay, maybe there's a bunch of outlier shifts, and maybe that's actually a trend, and maybe we need to do something about that based on historic data. So all of those things kind of come into play.
For sure. Yeah. I mean, I think EM is especially like unique. We have a couple of things that make it different than a lot of other specialties, like just the breadth. And, a lot of people, you hear them say this, like, you're training in EM so that you can learn this as you go on, right? There's no way you can learn everything in training. And, that's definitely true. That makes it really hard to assess, trainees is to like, are they ready for practice? Because they probably aren't going to have a chance to do everything in the scope of an EM during their training, and then on top of that, our training is, to be honest, is shorter than a lot of other specialties, especially those that are procedural or have a procedural component to them. So I think that makes it really challenging, like, do you think that with this competency-based education, there inherently will then be like a push to incorporate some flexibility into the training length, or like how's that going to what effect is that going to have on the institutions, I guess, when people are moving towards a competency-based system, and some are going to progress much faster, right? When you're talking about learning curves, some are going to be like almost practice ready at the end of their second year, beginning of the third year, and some might be on a trajectory that looks like, and it's going to take them a lot longer. If we're able to identify that sooner, what can we do? What steps can we take, or what are the implications for the system?
Yeah, so I think, everyone's always thinking about early identification of those who are going to struggle, right? And the earlier you can identify it, the earlier you can intervene, and the more quickly you can remedy that. Especially if you kind of have this level of, here's where they're struggling, here's kind of the diagnostic assessment, here's what we actually need to do to intervene, instead of kind of like a lot of the shots in the dark that we often had taken in the past, where we're like, well, I think it's this, and maybe that doesn't work. I think a lot of people worry about competency-based education because they automatically jump to this time variable piece, right? And yes, that could create a lot of burden on the system. Competency-based does not inherently mean time variable. So competency-based simply means it's outcomes-oriented, that there is developmental progression, you're using all of those dots, programmatic assessment, coaching, and individualized learning. That is competency-based education, those 5 things. Time variable is the additional piece that we would aim for. There are some constraints in our system, i.e. funding, that make that tough. And then the workforce issues, right? Like we rely, for better or worse, on residents to take care of patients and for our hospitals to function. There are some interesting models out there that are called promotion in place, meaning if you have residents who are ready early, you can promote them in place to kind of an attending role or give them additional opportunities for professional development without losing your workforce and without screwing up your GME funding, which show a lot of promise, right? And then we've always had this kind of buffer where if you need to keep someone longer, you can keep someone longer. What we've seen generally is that it's 6 months on either end. Like it's not going to be like years where you're going to see people going out into practice early. From all of the data, particularly out of Canada, it's usually about 6 months early to 6 months late. And we generally kind of have that buffer, particularly in a promotion in place model. And a lot of us keep trainees up to 6 months late because they've taken time off for family leave, illness, like all sorts of things. And I think competence-based education actually allows for even more of a buffer for those kinds of things, because we've realized that a lot of our trainees do need that decompressed time in order to grow and develop and to be able to take care of the other things that like are important to them in their life. So I don't know. I think it's one of those things that people get hung up on a lot, but I want to kind of debunk like it doesn't have to be time variable. There are ways to go about doing this that don't completely blow up the system. And I think thinking about, at least the competency-based part and getting that down really, really solidly is going to be 95% plus of the important things that we need to think about and work.
I love it. Yeah, well, I mean, I think everyone's a little bit afraid, right, that their like GME funding is going to get messed up with
Right.
this, or there's going to be some other complications. But I do love the idea of like the promotion in place, because I think that's one area, like, our high achievers, right? A lot of the time, we're like, oh, they're fine, and they don't necessarily get the same like attention that
Right.
folks who are lower on the curve might get, like a little bit early intervention and things like that to make them kind of meet that learning curve. But like providing those opportunities to even our high functioners, as from a systems-based perspective of like, these people are showing that they're ready for increased responsibility. I love that idea. Do you know, are there any other even like non-medical specialties or other professions that are using this type of progression in place and competency-based education, and what kind of examples
Yes.
can we see from the real world?
Yeah. So we are not alone. Speaking particularly about promotion in place, there are a couple of models actually within the US that have tried to do this and have done so successfully. So there is a group at Brigham Mass Gen that has done this in their pathology program pretty successfully, and then a pilot out of the University of Cincinnati in internal medicine. So they've shown that promotion in place is certainly possible. From a competency-based model perspective, there are a host of folks, and the entire country of Canada is doing competence by design and is kind of learning these lessons as they go. The Netherlands has been working on this for a long time within medical education. And then outside of medical education, veterinary education has been doing this for a while, and it's starting to come to fruition in the States, which is really cool. And we've seen this in nursing education, dietetics, actually, in Australia. There's a host of kind of groups that have bought into this, largely in health professions education. But competency-based education has actually been tried and been around even in elementary education in years past. So it's definitely something that's been part of the conversation, and in medical education really brought back to the forefront, from about 2003 when you saw EPA surface to 2010 where you saw like the real imperative for competency-based education. It's definitely exploded since then within our field.
Awesome. Well, I think after hearing you talk about this, I'm fairly convinced that we need to overhaul things a little bit. But for me, like, I don't have a lot of experience with this. So if I'm interested in kind of trying to see which direction this is going to go and what the future holds for us as educators, what kinds of things can I do to try and either get involved or learn more about this or bring stuff back to my institution to start considering this?
Yeah, absolutely. So obviously come to the keynote in May. I believe it is Thursday morning for those who want to get up bright and early and come hang out with me. We will be having the SAM Consensus Conference in 2025 in Philadelphia on competency-based education. And there will be work groups for the entire year before that we're going to start putting together, looking at how to go about, kind of getting each of these core components of competency-based education off the ground and thinking about the sticky implementation issues and research and scholarship around this, the next like 10-year agenda, because this is going to be something that I think we're going to see implemented specialty-wide within the next several years. We also have this big grant with the American Medical Association looking at doing this, and we've been doing it at a pilot group of institutions. There's about 10 of us now, and we've been working on doing this from an assessment perspective, implementing coaching, individualized learning, and looking at kind of, what are best practices across institutions, what's acceptable variability, all of these different things. If you want to get involved, you can always reach out to our team. We should have a website up and running within a couple of months where you'll be able to kind of say, I'm interested in joining, because we're going to expand the pilot probably within the next year in the run up to kind of trying to take this specialty wide. So there's a host of ways that you can get involved. And if you're interested in just reading more about it, there are a bunch of great papers that have come out in supplements in medical teacher from the International Competency-Based Education Collaborators Group over the years. handful of good supplements if you want to go back and look at those. But I will probably have each of those collections posted or part of the app for the keynote, so you can read more after that as well.
Well, I'm really looking forward to your keynote and hearing more about this. Like she said, on Thursday, make sure you attend that keynote so you can get all the lowdown on competency-based education. It seems like, certainly this is coming down the pike for us, not just in EM, but in all medical education. So thank you so much for being on the forefront and something that you're really clearly passionate about throughout your career, medical education and scholarship. So thank you for all your hard work, and we wish you the best. And we'll see you soon, SAM 24.
Awesome. Thank you so much for having me, and I will see you in Phoenix.